Thank you for the kind introduction. And thanks for being here physically for the last topic of the day. I would like to thank the organizer for inviting me here today to share Singapore experience of advanced practice nurse-led geriatric syndrome screening clinic. So there's no doubt that we are facing a growing pandemic. In our region, as we are speaking now, 1/3 of the PL-HIV population aged 50 years and older. People aging with HIV experiencing significant functional impairment and also cognitive impairment. So geriatric syndrome is prevalent. And the sarcopenia in PL-HIV is reported to be at 24%. This study reported a pool prevalence of 4 at 26%, of which 14% being recurrent falls. In this systematic review, they reported more than half of the population that being in a free or peripheral state. And of course, cognitive impairment is also prevalent among our patients. So, why is screening important? We know that HIV infection accelerates and accentuates biological aging through multiple pathways like chronic inflammation, immune activation, and cumulative exposure to ART. And this gives rise to high prevalence of geriatric syndrome. We also know geriatric syndrome associated negatively with patients' QOL and as well as functional status. And this was often undetected in the routine HIV follow-up. This signifies that single disease model of care failed to address a bigger picture. So how do we provide geri care to PL-HIV? There are several successful surveys globally. We can broadly categorize them into 3 models. Model 1 is a routine geriatric or outpatient referral. So the challenges lies in patient barriers and the referral barriers. For Model 2, we can see it combines HIV and the geri service in a multidisciplinary clinic. This is promising, however, may face issues like funding and sustainability. Model 3 relies on a dually trained provider. It also seems to be an ideal model. However, now it's rare due to the workforce availability. So recognizing these limitations, we take an innovative approach by having an advanced practice nurse provide a geriatric syndrome screening clinic. This will balance scalability, workforce availability, as well as patient accessibility. So, geri syndrome screening clinic rooted in a multidisciplinary care approach. The core team involves HIV physicians, geriatricians, and the infectious disease APN cross-trained in geri care. And this team is supported by the clinic operation team, nursing team, as well as our enhanced HIV program. So the scope of this service aims to provide comprehensive geriatric assessment to people who have biological aging, regardless of age cutoff. So you can look at this as one of the examples of intervention that were provided for patients with cognitive impairment. It's quite comprehensive. Now I will walk you through the GSSC workflow. PL-HIV with age 65 and above will undergo frailty assessment at the triage touch point by nurses during their routine HIV visits. For those who have CFS 4 and above, the primary physician will be notified to refer case to GSSC. For people who is younger than 65 years old but with significant Geriatric syndrome, they can be also referred to GSSC for comprehensive geriatric assessment. And then the APM will initiate interventions, followed by a multidisciplinary meeting with the geriatrician and the HIV specialist to plan care ahead. So now when we adopt screening tools in our CGA screening, we use locally validated and context-specific screening tools. We take reference from Singapore National HIV Program primary care recommendation, as well as recommendation from a geriatrician. So I will share some example here. The first one is a clinical frailty FAST. So this is a very good tool used to assess frailty. It is a validated tool used in our emergency department for people who's aging 65 and above in the general population. The nurses have to ask no more than 3 questions to score the CFS. It's pretty robust. The second example I would like to cite is that we use local relevant of the age cutoff point, of the cutoff point for age and education level adjusted for our objective cognitive screening tool, which is the AMT and the Chinese Mini Mental State Examination. So you can see the table below shows the cutoff point for different age and education level. So with this consideration and preparation, we have the APN-led GSSC service up and running. And now I will walk you through very quickly on domains of our assessment. So we screen functional status with BADL and IADLs. For cognitive function and history taking, we usually do it at the very beginning of the clinic session, so that our patient still energetic and have a good concentration level to ensure a fair performance. Fall history is something we are very meticulous. We will ask fall history on every single fall incident to elicit any predisposing or precipitate factors so that we can offer tailored intervention and the patient education on fall prevention. For sarcopenia screening, we are also using a multiple modality tools here. So what have we learned from our patients so far? About half of the GSSC referral are actually for cognitive impairment. And interestingly, most of this are actually from subjective complaint of poor memory, forgetfulness. They correlate poorly with the objective cognitive screening test done. And also, when we look at the domain that they actually don't do well is usually poor attention. And when we drill deeper, we realize there's multiple modifiable factors that can be identified in a single case. For example, mood issue, substance use, and as well as poor sleep. So followed by that, frailty also scores the highest, the second highest at 38%. The top 3 Geriatric syndrome that we have noted are polypharmacy, cognitive impairment, and frailty. And it is understandable that some of our patients also experiencing polydoctoring. So we collect data every quarterly to monitor the service outcome through multiple domains. We look at the number of patients screened, referral take-up rate, as well as patient satisfaction and provider feedback. So now I will walk you through a patient story to further illustrate GSSC model of care. We have a 73-year-old Chinese male. He's referred to Jerry syndrome screening clinic for subjective cognitive impairment. He's single, stays with elder brother. He has no formal education but able to read and write Chinese. He has well-controlled HIV on dolutegravir and lamivudine. His other significant medical history involves a lower urinary tract symptoms with overactive bladder, on follow-up with urology. He has cataract status post-surgery and also eczema, on follow-up with a dermatologist. Functional status-wise, he has no major issue. He has CFS score of 4, which is in the pre-fill state. Cognitive history revealed that he has self-perceived progressive forgetfulness for the past few years. He has some positive short-term memory loss, but the rest of the domain are all negative. If you look at his objective cognitive screening test, he scored AMT 9 upon 10. His Chinese mini mental state examination is actually 21 over 28. Adjusted for his age and education, this is not too bad. Otherwise, his mood is generally okay. He has significant complaint about poor sleep. And also, he visited different general practitioners to get sleeping pills, procodine, diphenhydramine. So he has increased sleep latency with racing thoughts. And he also excessively worried about a lot of things. Physical examination and investigation are unremarkable, and there's no other Jerry syndrome identified. Our assessment for this case is subjective cognitive decline. Possibly reversible factors are medication use that affects sleep, mood, and anxiety. Also, the anxiety symptom may be something that is standalone. So this timeline shows his progress in the clinic. During first visit, we conducted CGA, and we stopped the medication could potentially affect sleep, mood, and anxiety. We offered a referral to specialists, but he declined. We emphasized on sleep hygiene and follow him up. During the second visit, he has completely stopped using the offensive medicine, but his anxiety symptom persists. He is still not keen to see a specialist. During the third visit, this is where we start to build very good rapport. He be able to explore his goal of care, and his cognitive function still stable. And now he's keen to see a specialist for his anxiety symptom because he recognized that how important this has affected him. And he also agreed to do an advanced care planning discussion with me. So, reflecting on our surveys, that nurse can lead high-impact, scalable intervention to bridge the care gaps for people aging with HIV. Our surveys generally receive good feedback from both patient and the ID physicians. So, Jerry syndrome screening clinic is actually a misnomer because our service provide more services than just screening for symptoms. We also facilitate access to community service to enhance medication adherence, collaborate closely with social workers on complex HIV care management, also conduct advanced care planning, and document this discussion formally so that the patient's care preference is made known to other people. And many of them actually benefit from a longitudinal follow-up in the clinic. So, reflection on patient's care, we realize that the key thing is to establish patient's goal. The moment we know what matters most to the patient, we can better tailor our intervention, and we more likely to have an impactful care for the patient. Despite our success, challenges remains. So referral barriers is very common, and our consult typically lasts for more than 1 hour, so patient may be very tired. Our GSC service is actually a small step in exploring the possible integrated geriatric care into routine HIV clinic. But this offers a blueprint for other services to adapt and scale up. And we are also exploring to provide HIV care in a more convenient manner, possibly a co-located clinic that serve the function of HIV routine follow-up, geriatric syndrome screening, and the geriatric consult at the same setting. So with that, I would like to acknowledge Prof. Wang Chun-Siong, Dr. Justin Chu, and Dr. Choi Chao-Yi for providing invaluable support and guidance from the inception of the clinic till present. I'm also deeply thankful to clinic nursing team, clinic operation team, and our enhanced HIV program. So with that, thank you for your attention. I'm open to questions and discussion.